input from the public because that makes the process much more robust and we get good feedback, ensure that we get good feedback. So with that, what we'll do today is we'll go around the room, do the introductions. We'll have a little bit of background that Jonathan from OHA can guide us through, and then we'll have a first public input session. We'll have 2 of those today. Then we'll walk through the remaining items, 16 through 22, make some decisions on those. We'll have a little bit more discussion. We'll talk about next steps. We'll have another chance for the public, for folks that may have come in late, to provide some public input, and then we'll wrap it up. So with that, let's go around the room and have introductions from members of the committee. And I'm just going to go down my list that I'm seeing in my participants list. It may not be the same as yours. And so I'll start with Inga.
Good morning, everyone.
If you could introduce yourself, where you're from, and who you're here for in terms of representation. And remember, there's 3 groups of folks that are representation. There's the hospital representation, health plan representation, and practitioner representation.
Thank you. Good morning. My name is Inga Bard, and I work for Providence Health and Services for the Oregon region, all the 8 hospitals. I worked with Val Chris. She's the one that nominated me to replace her. She retired as of last month. And I know those are really big shoes to fill, but it's a pleasure to be here. I've been with Providence for 23 years. Prior to Providence, I worked at Blue Cross and Blue Shield of Oregon, and then I also worked from the group perspective for Health First Medical Group before joining Providence 23 years ago. So, nice to be here.
Thank you. Let's see, Karen, you're up next on my list.
Good morning, everybody. I'm new to the committee. I am working for Advanced Health as a health plan representative, and I've been with Advanced Health for over 20 years, starting in the claims realm, going into HIPAA and compliance, encounter data. I've done it all, basically, from the health plan perspective. I do have experience in both the clinical setting as a billing administrator and helped providers with their credentialing there, as well as I oversee the credentialing department here at Advanced Health. So I'm looking forward to working with you all.
Great, thank you, Karen. Ken.
Good morning, everyone. My name is Kane Lau, and I am the credentialing manager for Kaiser Permanente Northwest, and I am representing the health plan for this meeting. And I've been with Kaiser for about 15 years and been manager for 5 years.
Thank you, Keenan. Apologies on your name. Let's see. Who am I seeing up next here? Dorothy.
Hi, I'm Dorothy O'Keefe, and I'm a credentialing specialist with Legacy Health, and I'm here as a hospital representative. I've worked in credentialing for, I'm coming on 14 years, and I previously was on the committee as a health plan representative. I recently started with Legacy in a hospital setting, and I previously worked in a health plan setting for 13 years, so just switched.
Great, thank you. Is there anyone else I missed that's on the committee that I'm not seeing here? I know there's a phone number. Jonathan, are you seeing anyone else? You're on mute, Jonathan.
Had to do that at least once today. Dr. DeLowry is present as well. I'll let her introduce herself.
Thank you.
I'm Emma DeLaury. I'm a second-year internal medicine resident and a practitioners.
Dr. DeLowry, you're pretty faint there. Could you possibly turn up your volume just a tad?
If that works better. Sorry.
Still pretty faint, but I think we can hear you just a tad.
Sorry. I'll try to speak loud. I'm a second-year internal medicine resident and be representing the healthcare practitioners.
Great, thank you. And just a administrative note, we're 2 members down, Mr. Novak on the hospital side, Ms. Perry on the practitioner side. So those are 2 positions that we'll work to be filling. I know OHA has been hard at work filling the current slots that were open, and we've got our 2 new members, and so we welcome them. So there's still active recruitment going on out there, and we'll continue those efforts through this year. So if anyone has recommendations for folks from the hospital health plan, the practitioner side, please get those over to myself or Jonathan, and glad to work on that through this year. So with that, I am going to turn it back over to Jonathan to walk us through some initial business that we need to take care of before we move on to the first public comment.
Absolutely. Thank you, Mark. One more slide, please, Mark. Overbeck, sorry, my direct supervisor is on the meeting. He's advancing the slides for us. So I'll say Mark O, I guess, so not to get you too confused. Thank you for giving a little bit of background on the current ACPI membership as it stands. As you can see from this table, and as Mark spoke to previously, we currently have 2 seats that, as of the start of this meeting, have been officially vacated. Since this was a continuation of the 2021 meeting, I was waiting till this meeting actually adjourns to see whether Melissa Perry or Eric Novak would be present and choose to renew their terms. But since they have not chosen to join us today and been unresponsive to emails, yes, we will be conducting recruitment to fill those 2 open seats. As you can see from this chart as well, we have 3 new members today who just introduced themselves. Inga Bard graciously agreed to fill the role of Valerie Kriz as a hospital representative. Dr. DeLowry came on as a practitioner organization representative, and Karen Gannon is filling one of the health plan representative seats. We went through a pretty robust recruitment process last fall. We opened the period several times to try to get a diverse selection of candidates, and we ultimately ended up choosing Karen and Emma to fill those seats. We think they bring a unique and informed perspective to the committee, so we're happy to have them here, and thank you for being present today. All right, next slide, please, Mr. Overbeck. Okay, on to official ACPCI business and the approval of the charter. Charter should have been sent over in your combined meeting packet. We do need to officially vote on this. I know we did this during the meeting in 2021, but since there has been some transition in membership and the membership list has been officially updated to reflect the new members, we need to vote and approve that again. Although I will say now that those 2 seats have been officially vacated by those 2 members, I will need to revise this again. So Mark, perhaps we can vote to approve this on the condition that I revise to reflect those 2 vacant seats.
Okay, and so folks have that handy. It's at page 2 of the packet that was sent out. And given Jonathan's caveat, I'll entertain a motion for approval.
I actually have one notice of change that I sent to John prior to the meeting. On page 3 of the charter, it has my certifications listed as CPCS and CPMSM. That I am not currently a CPMSM. So I would like to have that removed for correction, please.
Absolutely. Yeah, apologies for that oversight. I will definitely have that
No
amended to reflect.
I also have a question, and it probably won't impact approving this as is, but it was brought up in the last meeting to look into revising the name of the committee from physician credentialing information to practitioner credentialing information and updating that on whatever documentation it's listed on.
Mhm.
And I just didn't see that noted anywhere, that request.
Mhm.
Do you know if that's something that got noted and is being looked into?
It definitely did get noted. It is going to be looked into after this meeting officially adjourns, and we'll be sending updates to the committee members once that occurs. So yes, thank you for noting that, Dorothy.
Okay, thank you.
Right, and it's a good question, and just a quick caveat on that. Unfortunately, when things are baked into a statute, which is part of ORS 441221, it might require a statutory change, so a legislative fix, but that's something that's been noted, and I guess OHA will be working on that. Is that right, Jonathan?
Yes, that is correct. I need to confer with some other members of the Oregon Health Authority before we look into how we can and if we can make that change. So,
All right, so we have a motion with Jonathan's caveat and the update to some credentials. Do we have any other questions or comments?
it looks like Dr. DeLowry has her hand up, as well as Karen Gannon as well.
Thank you, Dr. DeLowry.
Just for my affiliations, I work at OHSU, but I'm not like officially representing them on this committee, so I'm not speaking for them.
Okay, I will certainly get that updated as well. If you want, would you like me just to omit the OHSU from and just leave internal medicine resident on there?
That'd be perfect. Thank you.
And there was another hand up, is that right? Jonathan?
Yes, I believe that Karen had her hand up as well, or was that previous?
I removed mine. I forgot
Okay.
to remove it once I had it up. Thank you.
Absolutely.
Another hand, Inga.
Yeah, just a little nit. It looks like we have the education noted after the names, and mine. I also have a bachelor's in healthcare administration. Not sure how that matters, but wanted to bring that up.
You got that, Jonathan?
Absolutely. I am making note of these changes. So I will definitely work to get all the changes accurately reflected on there.
Anyone else? Emma, is your hand up again? Okay, okay. All right, well, a complex motion for our first motion. So we have a motion pending some changes that Jonathan has and some changes to the credentialing. I'll entertain a motion to approve.
I'll make a motion to approve with the changes.
Second, any second?
I'll second.
Okay, any discussion before we move on? Okay, all in favor?
Aye.
Aye.
Any
Aye.
opposed? Any abstain? All right, so just want to verify with you, Jonathan. I have a motion for 6-0 in favor. Is that tying with yours? So we have that for future motions. Great.
Yes,
All right,
that's
thank
correct.
you. All right, so we can
Next
move
slide,
forward.
please. Okay, so just give us some background here on recent timeline involved with the committee itself and changes to the credentialing applications. So in 2018, obviously the committee recommended for immediate changes to the 2017 practitioner credentialing and re-credentialing applications. And in March of 2019, the OHA director approved the changes the committee brought forth, and those 2019 versions were published later that year. Obviously, in 2020, the committee did not convene due to safety protocols due to COVID. And then in 2021, we held a rules advisory committee meeting that, among other things, mandated the use of the latest versions of the applications 10 months after public release. In 2022, we just now were informed this week, actually, that those rule changes were approved by OHA leadership and accepted by the Secretary of State. So the 2019 applications are officially mandated for use. And once we publish the 2022 versions, probably sometime in late spring, credentialing organizations will have 10 months to comply with using the latest versions. I want to stop right there and see if anyone had any questions on any of that.
Sorry, I wanted to get some clarification. So is requiring the 2019 versions, those are required to be used now, and then when the 10 months after the 2022 changes are published, those would be required to be used?
Yes, that is
Okay.
correct. Currently, yes, the 2019 versions are mandated as of right now. Seeing no other questions, I guess we can move on to the next slide, please. All right, ACPCI process review. And just one more, please. Thank you, Mark. So just to give the committee members and the members of the public present a high-level overview of the process involved with amending the applications. So the committee itself convenes on an annual basis, and in a period before it convenes, OHA opens up a period for stakeholders to submit recommendations to amend the applications. We open it up for a 6-week period. Then we take those recommendations, compile them into a single document that we send over to the committee. Committee convenes, reviews those recommendations, obviously votes to approve or deny those. And once that occurs, we take those recommendations that the committee has voted on to the OHA director, and he either approves or denies those. And then we undertake a publishing process, and once they are finalized, they're published online for credentialing organizations to use. And as I spoke to previously, once they're published online, organizations have 10 months to comply with the mandate to use the latest version. And I'll stop right there. See if anyone has any questions in this regard. Okay. Seeing none, next slide, please. Okay. And I think it's important to emphasize this. It's just to reiterate, especially for the new members, is the philosophy of the committee itself is really, and this is written into statute, is really to ensure that the practitioner credentialing application and re-credentialing applications are strictly kept as credentialing applications. The purpose of the committee is ultimately to minimize the administrative burdens with that comes with utilizing these specific applications, and to consider the impacts of changing the applications for credentialing process as a whole, and not to benefit specific organizations and the processes that they may be currently undertaking. Any questions from anyone in that regard? Mark, did you have anything you wanted to add to that and the philosophy itself? I know we had some conversations previously.
Yeah, no, it's always a challenge given the breadth and all the information that everyone wants to obtain. We are statutory driven, and I think it's really important to keep coming back to that statute from time to time. And I really do appreciate you including that in the materials. So, committee members have questions, they can refer back to the statute at any moment. So thanks for that.
Absolutely. Any other questions from committee members? Okay. Next slide, please. Okay.
So this is our first opportunity for any public input. Is there a process that you use, Jonathan? I'm new to this. Do the folks raise their hands? How do you want to queue anyone up that would like to speak as a member of the public? And this is for members of the public. The committee will be chiming in on the process here shortly.
Typically, we have members of the public raise their hands in these virtual settings.
All right, so we will see if anyone would like to provide some input at this time. Please go ahead and raise your hand.
This is, can you hear me?
Yes, could you just identify yourself
Yeah,
and,
I'm Steve
and where you're from?
Steve Godowski from Northwest Rehab Alliance and Therapeutic Associates Incorporated. I had some question about the transitions of the versions. Looking on the OHA website, it says that use of the 2019 version of the OPCA is not currently mandated. OHA intends to pursue rulemaking in 2020 that will mandate use of the 2019 version. We're currently in our system, we have it pre-filled for 2012 version. And so if we get some clarification, obviously if the 2019 version is going to be changed, then I haven't had any feedback from payers specifically telling us to change our version under our last audit in 2019. I'm sorry, in 2021. So what do you recommend, or what are payers requiring, or what are payers required to do? If somebody could clarify that for us. If you don't know, that's fine. I could always.
So that we just kind of discussed that, and Jonathan, I'll let you summarize that.
Yeah, it's a little confusing.
Yeah, absolutely. The website is actually on a list to be amended, and it's not just that specific section. So that needs to be amended quite quickly, actually, and to reflect current committee membership and to reflect the latest mandate to use the 2019 applications.
Okay. So, so when did the 2019 become a requirement?
It was actually earlier this week
Just this week.
Yes, the administrative rules were put into effect this week when the Secretary of State officially approved our submittal of them.
Is there a grace period? I thought there was a grace period when the rules put into a place to give time for the providers to switch over.
Yes, so there's a 10-month grace period for
Okay.
organizations to comply with the latest versions. Although I will say that we will probably have the 2022 versions published online before that 10-month mandate to use the 2019 versions expires. So
okay, so we're safe to use the old version from 2012 because the 2019 version became mandated just recently. So we're in the 10-month transition period to the 2019. But what you're saying is because of COVID and the delay, the 22 version will go into effect probably within the next 10 months. So is my understanding correct? So we should just wait for the 22 version to come out and then change over to that version. I don't want to go through the expense of switching to a 2019 version that's only going to be good for, a few months. Obviously, this is a payers, can mandate us to use whatever version they want. But am I understanding correctly?
yes, so the 2022 versions will be published online before the 10-month expiration of the mandate of the 2019 applications. So I can't advise you one way or another on what applications you want to use at what times. It's up to your organization and their prerogative. But yes, the 2022 versions will probably be published online in the next 3 to 4 months.
Okay. So I don't want to belabor the point. I know obviously with COVID, things have been sort of mixed up, but so the payers will start requiring, my understanding of the law is a payer must use the state mandated form that they submit to providers to sign. So we can wait, if I understand correctly, we can still use the 2012 version since it's still it was still within the 10-month grace period to allow for a transition in the industry. And then once the 22 version is released, we can switch to that version when that comes out. Am I understanding correctly?
So Steve, I'm going to jump in here. These are all really good questions. We are looking for public comment on the potential changes to the form itself. These are really good technical questions. And so what I would recommend is that you put those questions into an email to Jonathan at OHA, and then you're welcome to copy me as chair of this committee. And some of those things that the OHA can assist with, they can assist with. Other things might need some external advice, and you might have advisors in your organization. Is that helpful?
Yeah, I just want to make sure that following the rules, and because we're audited every year by payers, and obviously the payers we're an IPA. North Shore Alliance is an independent practice association. And Therapeutic Associates is a physical therapy company. So we want to make sure that we're doing things right when we're audited this year. So, okay, I appreciate your time. I don't want to belabor the point any further. So I'll follow
Totally
up.
Appreciate the comment. Very much appreciated. And again, Jonathan and his team at OHA are there to assist as needed. And, by all means, reach out to them directly. And you're welcome to copy me on that.
Okay, sounds good. Thank you.
Are there any additional comments from the public? Okay. Jonathan, I think we can move ahead.
Next step in the process, review suggested application changes, which is attachment 5 in your combined meeting packet. And as Mark spoke to previously, we will just be voting on the last, I believe, 6 recommendations that are on that spreadsheet.
So there was an update sent out earlier this week. I hope folks had that. We'll be picking up with items 16 through 22. And Jonathan, do you want to walk us through each of the items so we can move to discussion and then some decision making?
Absolutely. Mark, if you could stop sharing your screen and I will pull up the specific recommendations and share my screen, that would be great. Thank you. Give me just 1 second here, committee members. No. Apologies, wrong document.
And while Jonathan's pulling that up, remember too, there's 2 sets of forms that we're dealing with. And for folks new to the committee, there's the initial credentialing form and then there's the renewal form. And so when we look at this, we want to use both of those lenses because they're slightly different, but it's really important to keep those in different forms in consideration.
Okay, go. Can everybody see my screen okay?
Yes.
Okay, fantastic. And Mark, could you confirm we are starting on recommendation number 16, correct?
Correct, that's what I'm seeing.
Okay, so I'm just going to start off reading this one and then I will pivot over to you for discussion and voting for the committee. So recommendation number 16 was submitted by Carmel Miller from Pacific Source. Her suggestion is on the OPCA and OPRA is move the MPI number to the practitioner information section.
Okay, and just a quick caveat as well before we begin discussion here. It's always important to remember that especially in light of the public comment we just had. Anytime we change forms, that might require some system changes as well. And so we should be very mindful of, when we do go ahead and change the form, make sure there's a really good rationale and support for it. And that's why this committee is so important, to engage in discussion around that, and to make good informed decisions before we recommend a change. Is there any discussion on this? Does anyone want to lead that off?
Sure, I can start. So I think for both this and the next item, it can be helpful. I think it's a matter of how your credentialing system is set up, where your ID numbers are located, where this might be helpful to house the information in the application, but it's going to be different depending on group. And so I think this is more a matter of convenience for one group or one credentialing database and maybe not for everybody. I don't know that it necessarily adds value across the board to move everything to the first page unless it would be for the majority of people. I know for legacy, we house all of these ID numbers with the licenses and everything, so it wouldn't make a difference to us. It wouldn't necessarily benefit us, but it might benefit other people. So I don't think it necessarily has a positive impact across the board. I think it's one of those personal benefit or preferences types of things.
I would concur with that. That's what we've seen in our environment. Looking at the applications over the years, both the initial and recred, I've seen it kind of move around from time to time, but you get in a flow and there is no rhyme or reason. I understand that the MPI being with the rest of the licensures, I think that's totally appropriate. On provider end load, since we're just going from paper into an electronic system, I know on end load, I'm looking for an MPI with a social security number and a date of birth. But again, that's our process, our software. So the benefit of the all, I think it's just placement. And I think for, as a recommendation, to keep it where it is with the licensures. So that way everybody has all of that contained in one area.
Okay, that's good feedback. Is there anyone else that has any additional feedback? I see a hand raised.
Yeah, hi, this is Inga, and I also agreed to leave it under licensure, keep it in that bulk.
Okay. Any additional discussion before I entertain a motion? Would someone like to provide a motion what I'm hearing is that this change not be accepted. Am I hearing that correctly?
This change not be accepted for items 16 and 17 because the Medicare and Medicaid IDs are currently in the same area as the MPI.
You are pushing for efficiency. I'm not going to get in your way on that. So there is a motion on the floor for items 16 and 17 that they not be accepted. Is there any discussion on 17 other than what we've just engaged in? Any additional discussion? Because I want to make sure we've had a full airing of that. Okay, thank you. So there is a motion to not accept items 16 and 17. Is there a second?
I second.
I'll second.
Okay. Is there any additional discussion? All right. All in favor of not accepting?
Aye.
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 Any opposed? Any abstentions? All right, motion carries. Thank you. Jonathan, moving on to 18.
Okay, thank you, Mark. Recommendation number 18, submitted by Carmel Miller from Pacific Source as well. It's on the practitioner credentialing application and re-credentialing application. So add a spot for race and ethnicity to assist with the compliance and reporting information to regulatory entities. and she submitted her kind of research on which organizations require some of this information as well. So that's what's in the parentheses there.
So these reporting requirements are quality reporting requirements and not credentialing requirements. They're not required for the credentialing process, is my only feedback on that. So during, having to actually process a credentialing application and getting audited for credentialing itself, NCQA coming to audit your file, they'll never look for race or ethnicity. So, I mean, I think that, I don't know unless something's changed, I don't know, Kane, being the health plan representative, something's changed this year where they've incorporated that into the credentialing standards, but to my understanding, that's a quality reporting requirement, not a credentialing reporting requirement.
I would agree with that. How we capture it, again, as an example, is we have an additional set of questions through our software that we have the practitioner answer those questions for the quality section, not the credentialing. So with regards to the state standards, I would recommend that we leave it the same.
I agree.
Is there any other input from the committee? If there's anyone from the public, we're going to have a second public comment section toward the end. Anyone else from the committee on item 18? Is there a motion? Would anyone like to make a motion?
I'm happy to make another motion that we keep what's the motion for, to not change the application at this time in that section.
I second.
Second.
Any discussion from the committee? Okay, all in favor of the motion?
Aye.
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 Any opposed? Any abstentions? All right, the motion carries. Thank you. Jonathan, item 19.
Okay. Recommendation number 19 was submitted by Carmel Miller from Pacific Source as well. And on the practitioner credentialing application and re-credentialing applications, add the following to assist with compliance and reporting information to regulatory entities such as OHA, CMS, and NCQA. So add a spot for a provider to indicate if they are bilingual and what languages they currently speak.
I'm going to make the same comment.
Okay.
It's the same.
That is a quality reporting requirement.
I agree.
I agree.
Okay. Any additional comments from the committee? Would someone like to make a motion on item 19?
I'll make a motion to deny this time.
And
I'll
second.
second the motion.
I'll
Okay.
second.
All right, any discussion? All right, all in favor of the motion?
Aye.
Aye.
Any opposed? Any abstention? All right, the motion carries. Thank you. Jonathan, item 20.
Recommendation number 20 submitted by Carmel Miller from Pacific Source as well. On the practitioner credentialing application and re-credentialing applications, add a spot for areas of focus and conditions treated. Apparently this is adhered to by the Washington Department of Health, and this will help assist with compliance and reporting information to regulatory entities.
I teeter on this one from the point of the health plan because we do have to pinpoint at the time of credentialing what the practitioner need, or there's populations, if there's specialty populations that they see and that type of thing. But from a credentialing standpoint, if we're just strictly doing black and white, again, it's a quality capture and that type of thing. I don't know if other committee members have any other input.
This is Kane. I think that information could also be captured in specialty, because otherwise we would open it for, it could be anything.
True, and I've seen that because I know that some providers will go and put a specific taxonomy code as their specialty, but then they'll have subpopulations that they also treat. I mean, they may have psychiatric nurse practitioner, but then also subspecialized in child and adolescent behavior. So it gets kind of tricky, and the reporting mechanism on a provider capacity report or a directory, it is beneficial to have that information captured at the forefront. So again, if you're looking for black and white, you know, if you use the source of truth as the MPI and the board specialty, then we use that.
Yeah, that's the only thing with area focus. It's that it's not the information that you primary source verify during a credentialing process. It's just collected information for, you know, the areas of focus, you know, what a provider specializes in, you know, like if they see veterans or if they certain populations or certain, you know, subspecialties, but it's not the primary source verified information. So it's a little bit outside of the credentialing process again, but
Yes,
it
kind
is
of
helpful
gray area.
information. It is necessary for certain groups again.
Further discussion from the committee.
As from a provider perspective, I'd say it's, I mean, that can change a lot just depending on where you are in your career, even within a single year. And some people are obviously going to put a little more detail into what they consider their areas of focus and the conditions they treat, and other people who may treat and the same populations may put less detail. So you may not capture all the aspects that you're trying to capture.
Thank you, Emma. Anyone else? And it's important to remember too that if more background and support and rationale is needed, we could always say no at a particular point in time and then work with OHA to get more information before you undertake the vote. And we always kind of operate under that statutory rule that's akin to a minimum necessary rule, if that makes sense. And so I hope that's helpful. Is there any further discussion on this item? I know there was the word teetering used, but is there a motion on this item 20?
I move to deny.
Okay. Is there a second?
I'll second.
Any further discussion on item 20? Okay, all in favor of the motion?
Aye.
Aye.
Any opposed? Any abstention? All right, thank you. The motion carries. Jonathan, item 21.
Okay, item 21, submitted by Carmel Miller from Pacific Source as well on the practitioner credentialing application and re-credentialing application. Add spot for cultural competency education in the CME section, or option for provider to indicate they need training from a CCO. This will assist with compliance and reporting information to regulatory entities.
Point of interest. I know that the cultural competency piece is now becoming, and I can't say for sure which entities do it, but I know cultural competency is becoming part of the application process for the licensures. So this may not, it may be, you know, a moot point here in the next year or so. Because I know like the Oregon Medical Board is moving that way. Please help me, colleagues, if you know of any others, but there is a strict movement to help that become part of an everyday process and requirement for licensure or certification.
And this is Inga, and yeah, you are correct. I did read it on the Oregon Medical Board that it's going to be a requirement for providers.
And again, I think it's a preference. I know that we, again, have a separate questionnaire that we send out asking all of this information, but it's more for quality and reportability back to the regulatory agencies. It's not NCQA, it's, none of the above at this point. It's not recognized that way.
And I think that's an important point too, even though we would really like to have a one-stop shop for everything. And that would be, sort of helpful to practitioners. Nothing prevents a credentialing body from asking those additional questions that they need for other regulatory and compliance and quality purposes. Any other discussion on this item 21? Does anyone have a motion with respect to item 21?
I move to deny.
Is there a second? Any further discussion? Okay.
Miss Miller's not going to be happy with us.
All in favor?
Aye.
Aye.
Any opposed? Any abstentions? Okay, the motion carries. Thank you. Jonathan, I believe we're at item 22.
All right, number 22 and last recommendation for the 2021 ACPCI meeting is on the Oregon Practitioner Credentialing Application and Recredentialing Application, adding a new section for race, ethnicity, language, and disability data, otherwise known as REAL-D. And Mark, would you like me to give sort of a little bit of background on this one, since this may be a pretty robust discussion?
Sure, Jonathan, thank you.
Absolutely. Just to inform the committee, and some of you may be aware of these things, but after some background research, I ascertained that REAL-D data is not a federal standard by any agency that I could identify, either the DNB, CMS, and REAL-D data is also collected by the Oregon Health Authority in numerous other ways, including by our Health Policy and Analytics Healthcare Workforce Reporting Program, who sends surveys to the 17 licensing boards throughout Oregon and collects this data for providers in other ways. Mark, I know you had some additional thoughts on this specific recommendation as well.
Sure. I mean, again, I do appreciate all the questions that this person has put forward and suggestions. I think they're important. And again, we've got to keep going back to what the function of these two particular forms are here in Oregon. With this particular question, in sort of getting under the hood of it a little bit, it does really seem to need some additional background research, maybe, perhaps even some legal input on it that I don't think we really have the ability to get immediately on. But given the importance and the policy behind REAL-D, I think it'll be helpful for us to have an initial discussion here and see what questions there are from the committee and what might be helpful to get some more background information on, if that makes sense. So let's open it up for discussion and see what folks are thinking about this question, this suggestion.
I live and breathe in this all the day, all time, because again, everything that the Ms. Miller has proposed to us on a health plan piece, we're having to feed that information back to the state, whether it be in a DSN or a quality matrix type of thing. And I was, for our plan, our HR department brought this to me to see if we could start capturing some of this information already during the credentialing process. Again, like you pointed out, it's not a federal mandate type of thing right now, but with the current movement in trying to identify and allow individuals to identify themselves, I think it's going to be a standard, in my own opinion. I don't know whether to go for it right now or wait to see how it hashes out and if it ends up being a federal mandate.
Other thoughts?
So I also have worked a lot in reporting and the quality data as well previously when I worked in health plan settings. And I mean, I agree, all of that data is very, very valuable, and it may, that's really interesting to hear that it may become a credentialing standard. Um, I I think though that, in regards to requiring providers to fill out credentialing paperwork, it really, really is important. The document's already, 12 pages long, which is not a horribly long document by any means, but limiting it to what is required for strictly the credentialing process is really important because we get so many recommendations every year, and that's really a good kind of focus to maintain. And then if it becomes a standard, then that's great, and we can incorporate that really easily. And in the meantime, different entities can, create an addendum that they send out. I've worked with entities that have done that, and to be able to collect that data. And I just think it's important that we don't inundate the application with too many things unless it becomes a requirement specifically for the credentialing process, unless it's something that really, even though it may not be a credentialing requirement, is something that is used and done by credentialing uh, uh, people, because I can't think of the word, credentialing people like us,
Right.
uh, across the board, just as best practice, even if it's not a requirement. But collecting languages and ethnicities and disabilities is not something that everybody does across the board. And so I think that maybe limiting that to having different plans or entities do an addendum until it does become a requirement would probably be the best thing to do, in my opinion.
Another point, this is also volunteer information. So applicants in our arena, their credentialing application is not going to be held out if this isn't completed.
Right.
So it's completely voluntary. That's why it's a survey. So right now, I don't think it's in our best or the best interest of the applications to move this into it.
That last point's a good point. I appreciate that. Other discussion? Hearing none, is there a motion on the floor?
I motion not to include it this time. Maybe reevaluate if it becomes a federal requirement. This is Inga.
Okay, is there a second?
I second.
Any further discussion? Okay, all in favor of the motion to not accept this suggested change?
Aye.
Aye.
Any opposed? Any abstentions? Okay, the motion carries. And again, with the caveat that we keep an eye on this, and that if we need to get further background information and even perhaps some legal guidance on it, I think that will be helpful for this committee down the road. All right. Well, thank you. We worked through that list. I'm trying to keep us on time as best as possible here. Jonathan, I'm going to turn it back over to you to pick up again with the slide deck.
Mark, this is
sorry.
Inga.
Yes, Inga. Yep.
Now, I have a quick question. So,
Sure.
So any other suggestions we have, we'll have to wait until the next revision. Is that correct?
Yes.
Is that what okay. Okay. Yeah, unfortunately, our team didn't have an opportunity to submit any, and I got a suggestion about a week ago, so that would have to wait then until the next revision, right? Okay.
Yes, unfortunately, I have to wait till we open up a period for solicitations, probably in the fall of this year.
Oh, perfect. Okay, this can wait until fall.
All right, Jonathan.
All right, the next item I wanted to bring forth to the committee wasn't an action item, whereas the committee isn't going to vote on it, but it was just an inquiry really on some questions that OHA has been receiving from various organizations within the credentialing field. And I wanted to get a sense from the committee on what was transpiring currently within the field of credentialing and thoughts on how we can help answer this question in the future. So to give an example, one stakeholder sent us over an email that stated they were using a new Verity product known as MSOW Portal, whereas a practitioner would fill out a series of questions, and those questions would be used to populate the practitioner credentialing application itself. And they were curious if this was in any way, shape, or form altering the application itself. So I was wondering if this is standard practice for credentialing organizations and thoughts that the committee has on things of this nature. And thank you.
Hi, this is Inga, and yes, for Providence Health and Services, we certainly use the provider portal, but we do not make changes to the application. We had an inquiry about, every page of the application had initial an area for somebody to put their initials on, which caused a lot of problems. So we asked, I think it was OHA, we needed to have a suggestion to remove that, and they said no. But those are the only, things that we can change, but it's usually making a little bit more room under the attestation questions. They're only entitled only like a line, so many characters. But other than that, we utilize the standard OPCA to interface with the provider portals.
We also use the MSOW portal and have it populate the OPCA and OPRAs. And I think also Cactus, when I worked at a prior employer, also has that capability of populating the state applications after filling out an online application. So I know other companies that do that as well.
I echo the same thing. We use MD staff, and it's exactly the same way. And the provider on the end has the final review process, and then it's submitted. So it's locked down before it's submitted through our portal.
Yeah, we have MD staff too, and it's the same thing.
So it sounds like what I'm hearing is this is pretty standard practice throughout all the credentialing processes, and it's pretty widely accepted by everyone involved. Okay.
Yes.
And well, that's pretty much what I was trying to figure out. So
I was going to
thank you
say,
so much. Oh,
just
go
a
ahead.
quick note, how it locks it, at least on MD staff, the application goes through, it has to be issued originally to the applicant who's going to initiate an electronic signature. But a user can come back in and help the applicant fill out the form, but will never sign off. So that's how the integrity is maintained before application is submitted.
And do most platforms have that type of protocol? Yeah, okay, I'm seeing yeses, so.
Yes.
Okay. Fantastic. Well, thank you, committee, for helping inform our decision-making process going forward. If there are no other questions or comments in this regard, I guess we can move on to the next slide.
Yes,
Oh.
thank you. So Jonathan, can you walk us through the next steps so the committee has the benefit of that?
Absolutely. Yeah, so now that we've officially voted on all the recommendations that OHA received during the last solicitation period, I will be bringing this forth to my colleagues that help me work on the credentialing applications themselves. We will compile them into one document, clean it up, and send it over to OHA leadership and the director for approval. Typically, approval process takes within 2 to 3 weeks upon submitting to leadership. And then we will be working with the OHA publications department to finalize the form themselves and post them online for all the interested parties, credentialing organizations to see. And as I stated previously, once they are published online, organizations will have 10 months to comply with the mandate to use the latest version. Any questions from the committee in that regard? Fairly straightforward. Good. All right. Next slide, please.
All right, so here's our second opportunity for public input. I know someone had their hand raised earlier, and so we'll open it up for public comment at this time. Please either raise your hand or let us know you're there on the phone, and then we can have some additional public input. A second call for anyone from the public to provide comment to the committee. Yes. Is it Desi Perez?
Desi, yeah.
Desi. Go ahead, Desi. Thank you.
So on the Real D data, I mean, you guys have said that it's not really part of the credentialing, but yet when we send over our reports to the CCOs and the state, we have to include that information. So, and that's sort of a credentialing process. So I was just trying to understand why you didn't feel it would be beneficial to add it to the actual application.
So did you have the benefit of the committee's discussion earlier?
I did, but I guess I didn't agree with that it's not a part of the credentialing process. If we have to start reporting on that to the state, and I know that the licensure, different licensure bodies are requiring it, to me that's sort of a part of the credentialing process. So I guess I was just surprised to hear that you didn't feel that that was a part of the credentialing process.
Dorothy, did you want to respond?
Yeah, so my input to that is that considering the application is meant to be a credentialing application for all types of entities, for clinics who are sending it to payers, for health plans, hospitals, CCOs, different types of groups. Not everybody needs to have all that information. Not everybody has the same reporting requirements. Not everybody has to do reporting. So to have all of that information required within a credentialing application, when it's not required technically as part of the credentialing process across the board, that was what part of our discussion was, that it's a lot of information to require from the front end when it's not really all part of the credentialing process. Those are all things that may be required in addition to credentialing for reporting, for quality, depending on the type of entity that you're with. But that's not necessarily what this committee is supposed to make sure is within the credentialing application itself. And that's one of the things that we talked about at the beginning of this meeting, as well as a reminder that we want to limit the application to only be containing information that's required as part of the credentialing process.
So
Desi,
sorry.
just again, this is Mark. Again, I think it's important to remember that our charge here as a committee is a statutory charge. And our responsibility is to ensure that the forms that we are, deciding what questions should be on or off the form, it's based on that sort of minimum necessary standard that we talked about earlier. With respect to this last item that we just discussed, is something that obviously we're taking under advisement, and it does need some more background, some more research And again, nothing prevents a credentialing body from asking supplemental questions. And we heard the comment earlier that some of this information is voluntary information, not mandatory information as well. So is there anything else you'd like to add, Desi, before we move on to another member of the public?
I just wanted to, I heard some of you say that you have additional forms that you send out. Is that something that you obtained? I was trying to look on the OHA to see if there was like a survey form for these questions, or if you just created your own. And that's my only other comment.
I can answer that. For our CCO, we included it as we create our own, basically. We took the information that was required on the RealD form and then added it as supplemental voluntary information for the practitioner. The credentialing system just happens to be the first point of contact. And that's why, and I totally understand wanting to grasp as much information as we can at the initial contact. But again, as was indicated, this group has to kind of take a back seat and look at the global benefit to all. And I mean, I would love to have all this information on the application so I could just plug it in and pull a report, but that's not what our charge is for this. So I hope you understand. Thank you.
Yes, thank you.
And Desi, thank you for the comment. We've got another hand raised, Tess Hawkins. Tess, if you could introduce yourself and where you're calling from and what your question is, or what your comment is.
Hi, thank you. Yeah, my name is Tess Hawkins, and I'm a credentialing specialist at Sky Lakes Medical Center in Southern Oregon. And I'm calling, hopefully, to get some input from Karen and Ing. You guys noted that you had used MD Staff. We currently are using MD Staff, but have been pretty shy to move towards MD App. You guys said that you would populate the information given on MD App into the Oregon application. Am I getting that correctly?
That's what, I don't know what Ing has done, but that's what our organization has done. I was actually the administrator. We just went to MD Staff, and we do have MD App, and I highly recommend it. Not that this is the place to do it or anything, but yes, on your application, check with your MD Staff, ASM's manager, or even the help desk, and they can help you add additional questions to your application.
Yeah, of course. So
And then it
when
can populate over into MD Staff for you.
Right, it goes directly into MD Staff, but did you guys repopulate that information directly back into the Oregon or the Oregon application itself?
There's
You didn't
nowhere
do
to
that.
put it. No, there's nowhere to put it. So
Okay.
MD, I'm sorry. You know what? Let's do this. John, can you provide my email address to her, and then we can take this offline?
Great, thanks, Karen. Appreciate it.
Karen, thank you. And I really appreciate the committee providing a little additional Q&A assistance to members of the public. That's really helpful, and thank you for that, Karen.
No worries.
And Tess, thank you for the comment. And I know Karen's offered to connect with you offline. And I see that there is another guest that would like to connect with Karen offline as well. Karen, you're the star today. Is there any other public comment for the committee before we close the second public comment session for today?
This is Inga. I just wanted to clarify for Tess that in Oregon we use MSOW and not MedStaff. But if anybody has any questions about our MSOW interface, I'm happy to answer any questions the public may have. But we are moving towards CredentialStream at the end of the year. I'm not sure if anybody else is doing that, but for now we're using MSOW.
Great. Well, I'm going to close the second public comment session. Thank you. And we are going to move on to adjournment. I'll entertain, if there's is there any other business, any other questions any of the committee members have here? I really do value your time. Thank you so much. I'll entertain a motion to adjourn.
I'll make a
I
motion.
second.
All right. All in favor, aye. The
Aye.
committee meeting is closed. And again, thank you for your time. Really do appreciate it. And Jonathan and Mark at OHA, really appreciate your assistance. Invaluable. Thank you. Have a
Thank
good day,
you.
everybody.
Thanks,
Bye-bye.
everyone.
Thank
Take
you.
care.
Bye.
Thank you, everyone. Mark, could you stay online for just a minute? Oh, no.
I can, John. I'm still here.
Oh, I meant Mark Bonanno, but yes,
Oh,
you should
sorry.
stay
No.
online as well.
Stop sharing then.
Okay, thanks.
Okay.
Actually, you know what? I'll just call you, Mark, directly. Stop recording.